Morning here in India, and we are happy to be part of Dr. Tin's meeting. The only unfortunate thing is that we are not able to be physically present there, but I'm sure you all will be enjoying there. The first patient, let me have the PowerPoint ready.
Yeah.
Show the PowerPoint.
Hello. Good morning, everyone. Greetings from MADRAS Medical Mission. This is the patient, Mrs. R, 55-year-old lady, diagnosed to have rheumatic mitral disease, underwent closed mitral commissurectomy through left anterior thoracotomy in 2007, followed by mitral valve replacement with 25 mm TTK Chitra valve, single leaflet mechanical valve in 2016. She complains of NYG class 3 dyspnea for last 1 month. She had a history of atrial flutter, which was managed medically. On examination, weight is 65 kg, pulse rate of 70 per minute regular, blood pressure 120 by 70 millimeters mercury, saturating normally in room air. CVS examination, JVP is elevated 2 cm above the clavicle. Cardiomegaly, 3/6 pansystolic murmur in the apex. Other systems normal.
You are going live.
Chest X-ray showing cardiomegaly with CTR of 60%, left atrial enlargement, mitral process ring in situ, sternal wires are seen. ECG is sinus rhythm, ventricular rate of 65 per minute, PR interval 200 milliseconds, QRS plus 75.
I told them to show
Echo.
the atrial flutter ECG and not this side. This PowerPoint is not working. Okay, Dr. Shak, we are going live on the echocardiogram. Echo live. Yeah. Show the echo live picture. Because get the echo live. No, we'll show it now. Show the echo alone live. Okay, thank you. Because echo alone live. Yeah, echo, make it bigger.
Yeah.
Good morning. This particular valve is made of an Indian valve called Chitra valve. This valve has got a peculiar characteristics where the disc is made up of ultra high molecular weight polyethylene, which is completely radiolucent. So you will not be able to see the disc on fluoroscopy at all. The entire assessment of the disc mobility has to be on echocardiography alone. What we will be seeing on the fluoroscopy will be the surrounding metal rim, which is made up of a cobalt chromium alloy. It's called as a Haynes 12 alloy. It's a single leaflet tilting disc prosthesis. Dr. Uma Mageshwar, my colleague, will be showing the echo live now.
Yeah. Good morning, everybody. This is the color Doppler interrogation of the TTK Chitra valve, which was showing. Previously, it was showing a normally moving leaflet, single leaflet. This is a color interrogation. And on X-plane view, we are able to see towards the lateral part, near the lateral appendage, we are getting a paravalvular leak. When we interrogated it,
ask him to show only echo.
Okay. On 2D dimensions, we are getting maximum of 10 millimeter. On X-plane and 3D zoom interrogation, we are able to see it was placed around, it is an oval shaped defect at around 9 to 10 o'clock. We can see the color jet flowing through that. Sir.
So with this information, go fluoro live. The 3D
measurements were same.
3D measurements was around 10 millimeter shack. On the 2D it was 12 in one dimension and 10 in the other dimension. So yeah, it looks hi Alison. Show the show the 3D. Yeah, show the echo big. At this particular position, the aorta is now in the, can you rotate the rotate Z plane, the aorta? Go to 3D, 3D button on the top. No, no.
One minute.
Okay. That rotate Z plane, it will be there.
No.
Okay, basically this is just posterior to the left atrial appendage. You can see the aorta, on 11 o'clock, and the leak is at around 10 o'clock. And below that there is an artifact. Increase the gains. Yes. Yeah. So the approach is basically to demonstrate our transapical puncture. Now about the utility of this technique for a lateral paravalvular leak, it's easy to cross through a transeptal puncture, a lateral paravalvular leak, and safely position a device transeptally, which means it is from the femoral vein. However, we just wanted to demonstrate the transapical puncture guided paravalvular leak device closure because it saves a lot of fluoroscopic time. So we are going to start our procedural time to be timed from the time we are getting the apical sheath inside to the time we are deploying the device, closing the apex and coming out. So as a preliminary, this lady being 55 years, we did a coronary angiography. The coronary angiography was normal. Next picture. And so this is the right coronary. Next picture. So we did one LV angiogram in order to locate the apex. So this is, you can see on the right side of the screen, a small needle that is being kept on the region where we are going to do the transapical puncture. It is just entering the skin alone at this point. It has not yet entered the heart, and we are just localizing the clinically palpable apical impulse, correlating it to the echocardiography, making a marker on the skin in that area, and we are positioning a needle in that area. So this is going to be our guide for the puncture. Now we are going live. Show here. Let me tell you, this case could be done very easily transeptally also, but this is just for the demonstration of this technique. So now I am palpating the apex in the same area where we have put the needle, and this is a standard normal 18 gauge puncture needle. With me to help will be Dr. Ronak, one of my associate. So apnea. So we are giving apnea in order to reduce the respiratory mobility. And now I am going in and puncturing the LV. So now I have started seeing the LV spurt. Go in. So Dr. Ronak is advancing the guide wire. So the guide wire reaches inside the heart. Now I am doing fluoroscopy. It has gone possibly through the aorta. Timer on. This patient already has got a left anterolateral thoracotomy for a closed mitral commissurotomy in the past. So there will be some scars around the apex.
You can give.
This was followed by the central sternotomy. So there are scars in yes. Now it has been connected again. Connect. So now we are entering into the heart. So you can see that the sheath is entering. So now I am taking. Hello. This is a 9 French sheath. Our anticipation was for a LifeTech 14 millimeter muscular VSD device, which is already loaded and kept ready. Sister, I want right coronary artery catheter with a straight Terumo guide wire. So the muscular VSD device, since it has got a fabric, it is going to ensure early closure. We can use an Amplatzer vascular plug, but the vascular plug, since it will not have a fabric, the closure is going to be a little later. It is not one of the small leaks, it's a little larger leak. Let me also tell the hemodynamics. The PA pressure was 90 millimeters of mercury systolic with a mean of 65 millimeters of mercury. It was quite a a significantly elevated PA pressure. So now we are, you have to hold it here and here. Yeah. Hi Zahid, how are you? I told the recent Zahid, the purpose was to demonstrate this transapical puncture, how it is being done. Show a little. Yeah. So echo 50% echo and 50% fluoroscopy. Yeah. So we are trying to get in through. Okay, get me LAO. I just want to see whether we are facing lateral or not. Go to LAO. This is right coronary. Ensure that your hand. Yeah. Show the heart. Show the. Take this injector out. Show the heart. So this is. Get a little cranial on this. So Uma, have we crossed? Just see. Go to RAO.
Have you crossed?
Yeah, 3D echo is real time. Okay, so the fluoroscopy shows that it is. You see that? Yeah. So now Uma, show me. Yeah. So echo person is try. Yeah. So now what I have done is I'm going to show the hemodynamics. Yeah. So now I am getting the left atrial pressure live. Sister, I want an amplathe superstiff guide wire. Amplathe superstiff guide wire, and then, so this is the left atrial pressure live. Show it on 50 scales. We have a left atrial mean pressure of around 32. Wait till it settles. So it is going little more than 40. Cut it down to, yeah, this is 100 scales. So we have a left atrial mean pressure of around 43 millimeters of mercury. The left atrial V waves are 56, quite a lot. And so right now we are getting ready for passing an amplathe superstiff guide wire. I'm going to take out my pressure transducer and connect it back to aorta. That's an amplathe superstiff guide wire with a long J tip. So the guide wire goes in, show the full heart. Yeah. So now we are taking out. In fact, now I will advance my sheath. So it is hitting against the edge of the, let me see whether I can pass, or else I will use a dilator now. Yeah, I will use a dilator. Yeah, for a LifeTech 14 muscular VSD device, I have chosen a 14 because my maximum dimension on echocardiography was 12, and you can appreciate that with the high LA pressure, this is really a fairly significant mitral paravalvular leak. So we are choosing a 14 muscular. Yes, Dr. Bharat. valve is it's a large valve. It's a regurgitant orifice of around 10 millimeter is quite a large defect. A regurgitant orifice area of more than 6 millimeter itself is considered moderate to severe. Sister, get the device ready. The box. The can you get the Doppler gradient, Uma? So this is the muscular VSD LifeTech device. I'll open it and show you. Make it larger and show the mitral valve gradient. Scales down. Yeah, good morning, Bharat. This is a reasonably acute paravalvular leak. This patient was operated only within 1.5 years, I think, and she has been quite orthopneic for the last many years. So now this is a LifeTech muscular VSD device that is entering inside. You can see the fluoroscopy, 50% fluoroscopy and 50% echocardiography. So now we have opened echo live. Yeah, echo 50%. So now I am withdrawing it slowly towards the paravalvular leak. Show the echo 3D. Yes. So now he will show both. So Uma, get on to 0 degree, 0 degree 2D and show the disc first. 0 degree and show the disc. Show the disc. Push it in. Push it inside. Yeah. Now get the leaflet perfectly aligned. No, it's not a good mobility. Uma, get it properly shown. It's a significant reduction in the mobility. Now let me see. Okay, I'm going to recapture my LA disc alone. LV. Let me see now. Okay, now Uma, you show me the proper leaflet. Yeah, so this is the leaflet. Get it properly aligned, Uma. Yeah, keep on showing that same view. It is 4 millimeter more. Reduced. So obviously this device is impinging. Open a 12 muscular VSD device. Or shall we significantly undersize? Get a 10 LifeTech muscular VSD device. 10 muscular VSD device. Yeah, possible. I'm getting a yeah, Dr. Bharat. Yeah. Yes. Yes. That. Yeah. I was just telling that. So we are undersizing by not by 2 but by 4 because we don't want to protrude into the valve orifice at all. So we are just getting the device changed into a 10 millimeter LifeTech muscular VSD device. Mohammed? Okay. Yes, actually that is also one good suggestion to use AVP2. However, because there is no fabric inside, the closure may be a little delayed, and it was a little larger leak, and so we wanted to get a fabric device. Yeah, 10 muscular VSD device. Ask him to give that. Ask him to give that. That is a 10 muscular VSD device. Yeah. So Alison, your preference will be for an AVP, and okay, yeah. So AVP. Okay. Oh, hi Nick. Muscular VSD. Sorry, Ilana. Which device, Nick? The 10 mm. The problem, Nick, it is not freely available in our country. We have used a few Occlutech Paravalvar leak devices before, but it is not registered in our country, and so it is not easy to get a quick supply. Now 10. I am loading a 10 now. In the same sheath, I have advanced the sheath into the left atrium. So concentrate on the 2D, Uma. Get the 2D perfectly aligned. So we are going in with a 10 mm. So again, fluoroscopy and echo combined. Yeah, he's concentrating on the valve now. Show the valve. Yeah, valve is moving right now well. Keep concentrating on the valve only. So now I have deployed the LA disc. Show the valve, Uma. So this is also reducing. Show nicely. Okay, so I am changing over to AVP2. AVP2, you get 18. See, this is a 12 mm leak. Yeah, so 18 AVP2. Alison, what will be the size choice of AVP2? The leak largest dimension was 12. Color. Okay. But it 10 by 12, yeah. No, but why two devices, Alison? It's a circular defect. Show the 3D now, live. A 18 AVP2. Yeah, 18. Hello? Dr. Zahid, you want to change the valve or what? show the leaflet now. Show the leaflet. So here the leaflets are okay. Show the leaflet properly. No, we are, yeah, it's a little staying far away. Show the LA disc. Yeah, so this is transiently the leaflet came. Yeah, yeah, so this is the, Uma, the moment you get the valve, fix the hand in that same position. Yeah, okay, so this is, the leaflet mobility is looking good. You can give a brief apnea. I think the patient's, okay, now just to give an apnea transiently. Okay, now get the valve properly, Uma. Yeah, the leaflet mobility is looking good now. So you want to say whether an Amplatzer vascular plug 1 could have been chosen? Okay, show the residual leak. Nick, one question to you about the occlutic paravalvar leak. Since the LifeTech muscular VSD device produced a impinging of the leaflet on the ventricular side, the same thing would have possibly happened with an occlutic square type defect, square type device also, because that also has got about 4 millimeter protruding discs on either side. And so you possible. Yeah, you probably with a very large muscular VSD device. Yeah, possible. Yeah, I agree. Yeah, it would have separated out nicely. Actually, there is some little bit. This is the leak, but that is happening through the device. So I think we have to wait out for some time. So I'm going to release the device. The position seems to be good, and next will be we have to close the apical hole. I want a 8/6 LifeTech PDA device for the apical closure. Yeah, Alison, if it happens, I'll be very unlucky. Yeah. Yeah, we can, yeah. Yeah. I will show you. Right now, within another few minutes, I will show you. Show the disc now. Show the disc. Show the disc properly. Yeah, the disc is moving well. Yeah. Yeah, the disc is looking good. Come, get an 8/6 PDA device ready. So we are going to close the apical. That was not ordered. No? So we are now going for the apical device. Yeah. Yeah. Can you show more echo? Echo big. Sister cable ready. Yeah. Short sheath ready. Yeah. Show us some hemodynamics. So, okay, this patient had an amputated left atrial appendage following the previous closed mitral commissurotomy, which was done prior to her the surgery. The mitral valve replacement was the second surgery. Previously, she had another surgery, which was closed mitral commissurotomy, during which time the left atrial appendage was opened and it was partially amputated. You get a contrast on the side arm. It is a duct occluder device. It is going to be it's a 9 French puncture. So I am going for 8-6 duct occluder. I will place the aortic disc well within the left ventricular apex. Dr. Ronak is going to make some small angiography as I am coming closer to the LV apex. Show the apex. So right now keep injecting small amounts. Keep injecting small amounts. Keep injecting. Keep injecting. Keep injecting. Keep injecting. Okay. Stop injecting. Okay. So right now we are going to release the timer. What is the timer? Actually, it's 24 minutes shack. We took a little longer because of 3 device upsizing, downsizings and all. Echo, 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 show the echo. RCA. Yeah, definitely. That is, I am not very familiar with the use of per-closed device. AP view. Show the fluoro. Show fluoro. Show. Show the. We don't have too much of experience in using per-close in the vascular system. I'm just getting a PA pressure as Dr. Bharat has asked me. Yes, I'm just getting in. 1 second. No, just a second. Record PA pressure and aortic pressure simultaneous. The previous pulmonary artery pressure was 90 millimeters systolic. 90. Now, let me show you. This is around 60. So pressure big. Hemodynamics. Get the